So while Sandra does that, let me start off by saying that hopefully the educational process that we start here will continue as you take the information that I give you and take it to your neighbors, your friends, your family
While
members,
Sandra does that, let me
because I think the key is to educate our fellow women in this case, to help us overcome some of the prejudices that the medical establishment has toward this particular problem. So I actually asked the first question because there's about 30 questions which you guys submitted, and I'm going to do the first question myself. And that is, what does premenopause, perimenopause, or menopause really mean? When I first started this process, I started an institute called Menopause Institute because I was utilizing terminology that I learned in medical school, residency, and fellowship. And yet it had really no meaning after a while because a 9-year-old girl is premenopausal. I have no idea what a perimenopausal woman is, even though there are companies that are based on treating, quote, perimenopause. It could be a 26-year-old woman with PMS. It could be a 60-year-old woman who doesn't want to admit that she actually is hormone deficient. And a postmenopausal woman could be an 85-year-old woman with severe osteoporosis, or it could be a 52-year-old woman who just has a dry vagina and inability to perform sexually. So really, clinically, it had no meaning. So I redefined the terminology as such so we can help understand what it exactly is we're dealing with, because unfortunately, language just has its limitations. So what is it that we're dealing with? And I'll tell you. Diabetes and insulin is the great model. So if you're deficient in insulin, you're diabetic. If you're pre-diabetic, you usually have too much insulin. That's it. So once you're diabetic, meaning once you have no more insulin, you need insulin for how long? The rest of your life. Why? Because the hormone is deficient. Similarly, in our hands, we do define exactly what it is that you need, not by symptoms, but by the reiteration of your symptoms with laboratory confirmation in the beginning so that we can confirm exactly what's going on, even though after a million patient months, I do have quite an understanding as to what you may need, but I still require everyone to get laboratory testing because sometimes we're not correct. So, are you ready to go ahead and start with the questions? So I figured I would do a filler there.
Yes, I am. Thank you so much. And if everyone can mute their just their screens, that would be very, very helpful. All right, so this question came in one of the registrations. I'm 58, hit menopause at 49, and now I'm experiencing extreme brain fog, poor sleep, muscle fatigue after workouts, and hair loss. My doctor is recommending HRT because we've already addressed other issues like low vitamin D and low ferritin hemoglobin, but I'm terrified of HRT because I don't want to feel like I'm going through puberty all over again. How do women know if they truly need HRT, and how should someone safely begin as a complete beginner?
Well, first of all, it has nothing to do with puberty. Puberty is the initiation of a cycle that first starts with estrogen, and then about 12 to 15, women begin to ovulate. This has nothing to do with ovulatory cycles. This is strictly a matter of replacing hormones that are deficient. In your case, it's particularly, the symptoms you're developing actually is a long-term deficiency of sex hormones that then induce an adrenal gland insufficiency called adrenal fatigue. So if you look at your symptoms, you have fatigue, hair loss, poor sleep, and brain fog. Those are mainly adrenal gland symptomatologies. So not only are your sex hormone deficient for 10 years, you also have the deficiency of adrenal gland, which needs to be investigated. I'm glad that you're getting nutritional testing like low ferritin with low hemoglobin, vitamin D, but we do more extensive testing than that. We check all your antioxidants, all your minerals, and your omegas. Nutritionally is the first level of building a house. That's your foundation. The second level is sex hormones. Third level is adrenal gland. And the fourth level is things like weight loss, peptides, supplementation. So that depends on each individual person.
Okay. All right, so this next question, what are the long-term effects of BHRT? And is hormone therapy considered safe for women with, okay, so, no, she changed that question. Okay, so
Okay,
what
with
are,
factor five, yeah, I see with
yeah,
factor five lady. So let me explain to you how we should approach this whole problem. The whole problem is that women need to consider the fact that their whole life they were on hormones. What my research really developed was what dosage of X hormone will give you Y level. So I had to study hundreds of women's levels, which nobody had done before, through their cycle to get an average. And the average is what I did. I multiplied by 28, and then I had a number, which then was able to divide it over a daily dose so that it's evenly spaced over the month so that you don't get a cyclic variation. So you really don't want to start bleeding every month when you're 62 years old. That took me about 3 years to figure out what I just told you. So once we consider the levels, which is the next question I see here, but once we consider the levels, the hormones are safe because we only give you what you absolutely need, the minimum amount to maintain you what we would call symptom free. There are 26 symptoms we had developed in our historical studies to clarify what it is that you need in terms of replacement. 26. So the standard model, the pharmaceutical model, is symptom relief. For example, all the things that you know you're experiencing, it's each symptom, have a drug to treat the symptom. You have an insomnia, take a sleeping pill. You have a dry vagina, take an estrase cream. You have mood changes, take an antidepressant. So you can have 9, 10 medications. When all you need to do, though, is study the etiology of those symptoms, which is not the pharmaceutical model at all. They make money on selling you particular drug for X symptom. So I had to go ahead and shed the prejudice that I trained with at very high quality universities that was absolutely incorrect. The way I approach it is that each particular symptom is contributory to a patient's lifestyle and how they feel. So unless you deal with all the symptoms, you're not going to be successful in hormone therapy. There are 4 groups of hormones. The next question I'll answer is what are the optimum levels for estrogen, progesterone, testosterone? And of course, the patient's missing the fact that the adrenal gland, the DHEA especially, and the cortisol levels need to be addressed. So there are no optimal levels. Everyone is different. Everyone absorbs differently. Everyone binds the hormones differently, something called the sex binding globulin. So when you say, what's my level? The trouble with most family doctors, internists, OBGYNs is they get lab work
Or get out of
and
here.
and they look to the right and they say, oh, you're within normal limits. Goodbye. Because normal limits for a woman who's 56 is pretty much zeros. So therefore, that lack of understanding and lack of education is very frustrating for patients. And what happens is that they go to doctor, and the doctors say the same thing. Family doctors, they don't educate themselves, they don't understand what the level should be because they didn't do the research. And they don't care. All they care about is let me get the levels that's normal, therefore let's put you on what? Antidepressants, a sleeping pill, an estrogen cream, and it goes on and on. Now the patch is very popular because some companies are pushing the patch, but the patch is just estrogen. Sometimes they give you a progesterone pill. Unfortunately, progesterone only lasts 10 to 12 hours, most. So half the time you have progesterone in your body, the other half you don't. That made no sense to me. So in other words, you have to understand the half-life, the biochemistry, which obviously you don't have to understand, but at least the practitioner should understand, but they do not. Okay, thanks, Sandra.
Awesome. Okay, so the next question is, one of the most emotional themes we're seeing from women is that feeling of I don't feel like myself anymore. Women are describing exhaustion, low libido, anxiety, irritability, depression even, lack of motivation, and just emotional disconnection overall. So what is actually happening hormonally during this phase of life that can make women feel so different from themselves?
Well, actually, dissociation or the way you feel about yourself, separate from your obviously physicality, is that hormones in women who have been constantly under the influence of hormone changing, once they lack those hormones or become constant, creates a lot of anxiety, a lot of emotional instability. So the trick is to understand that when a woman goes through the change of lack of hormones, you have to replace all 4 hormone groups to be proper in terms of how you want to get the great results. One hormone or 2 hormones, which a lot of programs do, they do an estrogen patch and a progesterone pill, is totally inadequate. Does not work 95% of the time. You have to replace progesterone properly, estrogen properly, testosterone to female levels, and the adrenal gland function, along with the nutritional assessment and replacement, and any additional medical problems that we see based on our history. So that's real. I mean, women do feel that dissociation. Normal response when you do not have hormones in your body that you've had your whole life. Very typical, very common. We also have younger women in their 20s and 30s who have the same sensation, the same emotional response, because they have anovulation, failure to produce progesterone for various reasons, including polycystic ovarian disease, premature ovarian failure, and they're told by their doctor, it can't be, you're too young, therefore here, let's send you to the psychiatrist. I see this all the time. It's actually very irritating because these women do not need psychiatrists, they need doctors who know what they're talking about.
Yeah. If any of you have had that experience, I'm sure many, please let us know in the chat or share an emoji of that's happened to you. You've felt like that. Um, so I think many of us have had that experience. Okay, so this next question, we're also just gonna ask. We're also seeing many breast cancer survivors asking questions about hormone therapy. There's a lot of fear and confusion out there. What conversations should breast cancer survivors be having with knowledgeable providers when they're exploring hormone-related symptoms and treatment options?
Okay, that's a very important question because we have about 500 to 800 survivors of breast cancer, various stages, and we have zero recurrence. If you properly replace the hormones, regardless of receptor site availability, you'll survive longer because your body's going to be balanced. Progesterone inhibits the breast cancer reproduction. Estrogen can stimulate. So you want to make sure you have the proper ratios of progesterone to estrogen. More importantly, your immune system is very important in the reduction of recurrence of breast cancer. It's actually, studies have been done, and oncologists don't admit it, but actually breast cancer is not a breast disease. It is an immune system disease. 1/3 of all women will exude broken up breast cancer cells on a daily basis. So they find the fragments of the anaplastic cells that are breast cancer in the urine of patients if they study it, because the T cell, the target cells will blow up the breast cancer cells and they end up with not getting breast cancer. So if we work on handling the immune system as well, which is what we do, which is what the whole nutritional program is, which is what the hormones do. Getting sleep, for example, increases your ability to fight all cancers, especially breast cancer. In my experience now, after 30 years, I have zero breast cancer stage 2, 3, and 4. We rarely have breast cancer with stage 1 or 0, yes. Would they have it when they started? Most likely. But it doesn't stimulate the breast cancer, it inhibits it. So we only see grade 1s, maybe rarely grade 2s. We don't see any grade 3s. Now, oncologists don't like to hear that because they make their money on breast cancer, especially advanced breast cancer. Now you have the fear component. There's no question that doctors who use the fear component should be ignored. You should not push fear into the patient to say, oh, you had breast cancer 17 years ago. I wouldn't take hormones no matter how horrible you feel. Here, take an antidepressant. I see that a lot. Oncologists are known for that. They will see the patient every year, get a mammogram every 6 months, and they keep on doing MRIs and all the testing. Meanwhile, the fact is that their cure rate is 99.99% doing nothing. So it has to be done in such a way where patients educate themselves, ask the doctors questions. What is my cure rate? What is my recurrence rate? And then they come to us and we go over exactly what we'll do and how we're going to monitor you properly to make sure that your estrogen level stays low, your progesterone level is adequate, and give you just enough hormones so that your lifestyle is better, your vagina works, you're able to have intimacy with your husband, you're able to sleep well, all the symptoms that you have, your lifestyle and your ability to function increases. And that helps your immune system work, which reduces your incidence of recurrence.
Okay. All right. So next question is, what is PTSD medical?
Good question. I developed that concept because I see patients every day who have PTSD medical, post-traumatic stress disorder medical. What is that? That is when patients go to 2, 3, 4, 5, 6 doctors, and none of the doctors make any sense. They begin to lie. They begin to tell things to the patient that they do not believe. They lose faith and trust of doctors telling the truth. They come to me and they're very, very defensive. They act as if I'm the enemy, and I sit down with them and I talk to them about their experiences, and everyone has seen 5 doctors who basically wanted to put them on antidepressants, tricyclics, sleeping pills, all the things I discussed. So I have to deal with what happened, and a lot of times, unfortunately, They have unnecessary surgery. I have patients at least once or twice a month that have hysterectomies to say that that's the reason why you're having symptoms. It goes on and on and on. So the best advice for you out there, if you're having these feelings that you don't trust the doctors, good, because you shouldn't. You should definitely do your own research. This is what this is all about. I'm educating you. We're going to continue to educate. We're going to send it out to our Facebook group that has tens of thousands of patients so that we educate our people, so that we make sure that people get the information they need to make the proper decision without fear mongering. If a doctor tells you things and it's fear driven, almost all decisions based on fear driven behavior, especially if it comes from a doctor, is going to be incorrect. Whenever you feel that inner feeling of, oh, I'm afraid he's telling me all these things that I can do XYZ, be very, very careful. And that's what I mean by PTSD medical.
Okay. Um, One quick question in the chat. Is it normal for postmenopausal women to have zero or low hormones, or is this a sign of disease?
Well, it's not a disease process. It's a natural process that women go through in this age of life, sometimes 30s, 40s, 50s, surely by 60. So I wouldn't call it a disease. It's just a deficiency of hormones that needs to be replaced. So it's not something that is that complicated. It's very simple. So when doctors use the word disease, I think that implies a lot of negativity. I'd like to just look at it as this is what you have, this is what can replace. We will check everything objectively, which means confirm everything that you going on with you with laboratory testing, and you need someone who knows how to evaluate the lab testing. As I said before, so many doctors don't even know what test to get, and they don't even know how to evaluate the lab testing. They look on the bottom, it looks like within normal range, and therefore they tell the patient everything is normal. So we know what values it should be because we use the average of 38 to 42 female that is out there still ovulating. That's the levels that we seem to be gearing toward that makes the woman most balanced and most happy. We don't want a woman to have pregnancy levels, but on the other hand, we don't want to have women who just have levels that are in their 20s and 22, 23. So that's
Okay, hold on, sorry, gonna mute. Um,
okay.
Right. Okay, so
What's
Charity
next?
will come back to your question. So what hormones actually decline during a woman's life cycle and how does it affect her? I mean, I think many of us feel it, but at what age can hormone changes actually begin for women?
Well, they change, they begin in puberty, of course. What we see is a lot of teenage patients who have birth control pill in their history and they have severe symptoms of hormone deficiency. It's previously undiagnosable. Now we know that birth control pills has a lot of negative effects on a woman's natural cycle, or you understand the need for it. However, that we used to think and used to use, and I was basically uh, writing scripts for birth control pills like crazy until I began to research the effects, long-term effects of birth control pills, which is the first level that young women are exposed to. Short term is fine, 2, 3 months, but after that, there's a lot of serious deficiencies of hormones that has long-term effects, and including infertility. So then you go into the 20s. Then you have things like endometriosis, which is an estrogen dominant condition. It's lacking progesterone. You have to balance that out. That's our major treatment. Uterine fibroids, breast lumps, breast fibromas, fibrocystic breasts. All of these in the 20s and 30s become relevant. Then we have a group of women who have what's called premature ovarian failure. That is that they're 20, 30, and their ovaries stop producing eggs and they stop producing progesterone and their hormones are whacked out, and the doctors tell them that they're crazy. So that's basically unfortunate, and that where PTSD medical comes in. We evaluate, we treat, and patients go on their merry way. We can't make them ovulate if they're not going to ovulate any longer. And the reason is because we're seeing a lot more premature ovarian failure than we ever seen before, most likely due to vaccinations and or environmental pollutants. So we see a higher infertility rate, a lower fertility rate, what's called a fecundity index, because also men's sperm count are dropping 1% per year. And a lot of that has to do with our toxicity in our water and food supply that we also try to address at our visits.
Okay, this next question is, can and how hormone imbalance, how can it cause anxiety, panic attacks, or feelings of depression, even if someone has never struggled with that before in their life?
Excellent question. So In the whole realm of anxiety, depression is almost always related to something called PTSD. PTSD, post-traumatic stress disorder, usually occurs from an event that is not resolved. It's stored in the subconscious. There's a lot of work that was done in that area. And recurrence is when a woman feels out of control, or if anyone for that matter, feels out of control. When you feel out of control, like your hormones are whacked out, okay, that will precipitate symptoms like anxiety, which really is a response, a normal response in the fight or flight conceptualization. And that was a normal, healthy response that you don't need medications for. What you need is to find out why the woman feels out of control, especially if she can't sleep, she has insomnia, she has sweats, night sweats, she doesn't have any sex drive, she can't have sex even if she does because her vagina is dry. And of course, she's going to feel out of control and get a lot of anxiety, which is treated with the symptom of anxiety as opposed to treating the cause of the anxiety, which is her feeling out of control as her hormones are not present to produce a nice, balanced, and healthy lifestyle. So another issue is that if you don't sleep, you're going to be anxious. You're going to be depressed. You're going to feel bad about yourself, especially when it has to do with additional problem of midsection weight gain related to the adrenal gland dysfunction related to cortisol. That's a whole nother conversation. But we do address that as well, but not primarily. That is really a secondary issue that we deal with patients because that changes your body image. You don't feel good about yourself. You go to the gym and you're still gaining weight. You go to the gym 5 days a week and you're still gaining weight and you're still getting a fat deposition in your midsection. And so it's very frustrating, and frustration can definitely lead to anxiety and depression. So when I see a patient, I quickly can sense that they have a lot of anxiety about their body image, and that's something that we address, but we don't address it primarily. Unfortunately, with the weight loss medications out there, especially GLP-1s, we're seeing doctors give those medications as a primary treatment regimen as opposed to a secondary treatment regimen. If it's given before their hormones are fixed, their nutritional status is fixed, their adrenal gland is fixed, it works temporarily, but it does not work permanently. The failure rate is about 80%. If you do everything first, everything is fixed, then you add the GLP-1s or whatever it is that you're using, the semaglutides, the tirzepatides, you get excellent results almost across the board. So body image is also important.
Okay. So
Was
with
was that
that,
too much? Was that too much information?
no, no, I think it was great. And feel free, guys, to chime in on the chat. But I know we want to sleep through the night, so what is it that, or what hormones offer? Why do so many women suddenly stop sleeping through the night?
Well, all the hormones are interrelated, but I would say if I have to pick a hormone, it would be progesterone. So a lot of these programs out there, they found out, they didn't listen to me. They found out through bad experiences. They were just giving patches, they're just giving pellets that they need progesterone to help women sleep. As I said before, a progesterone pill is not the same as a progesterone in other formats, and it only lasts 8 to 12 hours. So it helps the patient sleep, but then during the day, they don't have a lot of progesterone or any progesterone. Therefore, they're going to have more anxiety and more other symptomatologies that are related to progesterone deficiency.
Okay. So this next one is brain fog, which all of us fear, that's something that definitely gives us anxiety, forgetfulness or difficulty concentrating connected to hormone changes. Um,
Absolutely. Now, brain fog is a general rule, is related to two main hormones, progesterone and adrenal gland function. It is disconcerting today because we are focusing on women who sometimes think they have either early Alzheimer's or they have senile dementia early on onset. So what I do is you get a memory history, you get a cognitive dissonance history. You try your best to separate the medical aspect of it and the hormonal aspect of it. So what I always do is let's see what the hormones do. And I'd say 95% of the time, patients' memory improves, their sleep improves, which helps their memory. They also feel that the brain fog lifts almost right away. So therefore, there's a definite problem with family doctors referring these patients for neurological evaluation, which after $25,000 later, they say, oh, everything is normal. But they never think about sending them to the hormone person because that's not part of their mindset. They're into doing CTs, MRIs, like, over and over again, these tests, those tests. So therefore, now educating doctors, I get calls from doctors all the time. And I say, first things first, the easy thing is done. You can prove hormone deficiency in a 54-year-old woman who's developing foggy issues, memory loss, cerebration issues. Fix their hormones. And if 90% get better, you don't have to even waste the time and money sending them to a neurologist who knows nothing about these things, unfortunately.
Hmm. Okay, so
I hope
why do
there's no
women,
neurologists out there. They're going to get offended. Oh, well.
so why do women gain weight, especially around the stomach, particularly, even when their habits haven't changed?
Well, it's a multifactorial issue. What we do is we don't focus initially on the weight gain. Adrenal gland dysfunction related to cortisol. It's a lot of material out there on that, but they don't know how to replace it. So they say, yeah, your cortisol is excessive and you're doing this and doing that, but nobody knows how to replace it, but we do. We figured out how to replace cortisol. Hormone deficiencies causes the abnormal fat deposition. Now, a lot of other conditions, estrogen dominance, for example, and also genetics. There's a certain body type, the women who are big breasted, big hips, coming from mainly Northern European descent, will have estrogen dominance more often than not. And these things have to be balanced off with the proper balancing that we do, which is with testosterone and with progesterone. Now, do we use GLP-1s? Absolutely. I think it's a great advance, but only short term and only certain ones. Certain ones are very dangerous, a lot of complications, especially long-term management with weight without taking care of the other issues. So it's more complex than I think this is the indication for. But if patients have any particular problems, they can ask in the section, and we can connect with them through an email or through a phone call, and I can go into your specific case. But in general, I would say yes. We see excellent results, I'd say 90% of the time, in terms of weight reduction in the midsection secondary to hormone deficiency.
Okay. I want to answer this next question in the chat. And I know you just recently did a video on this, but why are troches used versus creams?
Okay. So for about in 1994, I started researching various methods. Took me about 10 years to figure out what levels are obtained with pills, with creams, with patches, with troches, which is a highly technical gummy bear, pills, suppositories, and these women were tested monthly to figure out what symptoms were relieved with what, and how did I quantify exactly what dose to give. No one had done that before in the history of medicine. And I came to conclusions based on the efficiency of the troche form, because we actually altered the troche form with a certain kind of gel, where my partner at Hazel Pharmacy in Pennsylvania helped develop, that creates an environment where we can put four different groups of hormones right in the troche, which saves a lot of money, easy to use, no messy creams, no patches, no peak and trough. See, peak and trough is very bad for women. They go up, they go down. The worst peak and trough medication that you can possibly do is the pellet therapy. It is horrible. It peaks way, way high. Women have testosterone levels well into the male range. Another peak and trough method is the patch. Regardless of what they tell you, the patch, which we checked hundreds of women, they peak and trough. They go up and then they go down. Well, that's not the way hormones are produced in your body your whole life. It makes no sense to me. It's not logical. Therapy has to be logical. Patients should understand that what I've developed is based on logic, not based on pharmaceutical research that wants to push drugs. We try our best to get people off drugs. Most drugs that are used chronically are not indicated, especially today, what we know about natural products and healing and things that are wonderfully available through supplementation.
Okay. So I'm gonna jump a little here. What
By the way,
is
let me add something. The GLP-1 studies that were done initially were done on probiotics, meaning that they found the probiotic produced its own GLP-1. So one of the first things I do when I ask people, are you on probiotic? No, I don't take a probiotic. Or I take probiotic, I get it at some store. And it's, not, I don't really care if I'm taking it. So therefore I tell them, the actual GLP-1 producing probiotic was how the GLP-1s were investigated and studied and now treated. So the first thing I do is make sure everybody's on a quality high dose, refrigerated, GLP-1 producing probiotic. And it's amazing how many women say, I lost 8 pounds. And so that's, I think, important little factoid that whoever attended this can begin to think about. But it has to be quality and it has to be from a company that you can respond to properly.
Okay. Um, I'm going to go to this question in the chat. How do you work with patients who have suffered with endometriosis? I personally had my uterus removed, but later learned I still had endometriosis cells around my colon. So it's required balance so that it does not get flared up.
Um, I practiced gynecology for many years, doing probably about 20,000 procedures, and I never did a hysterectomy on a patient with endometriosis until I treated her with high dose progesterone therapy, which counteracts the effects of the estrogen dominant tissue in the pelvic area, especially on the colon. So most of the time, surgery is not indicated. It's helped to treat the symptom of painful periods, especially if you have something called adenomyosis. My success rate was about 75%. So therefore, you can still now be treated with high dose progesterone therapy based on evaluation, which is particular to your case. So I think that's something you should look into. Yeah, we have a lot of patients referred to us by other gynecologists around the country for progesterone-based therapy to treat endometriosis after hysterectomy.
Okay. And we have a couple people asking your opinion on what probiotic do you recommend? I don't know if you have something now or maybe we could
Well,
send something.
there's various companies out there, and the most important thing is to have a company you trust in terms of research and bioavailability. In Hormonify, we have a long-term relationship with Pure Encapsulations. We discount Pure Encapsulations to our patients. They merged with Douglas Labs. They formed Atrium, and Atrium was then bought by Nestle. And it's the basis of the Nestle's international program to supplementation in terms of treating various conditions. So 20 years ago, when I got hooked up with them, I did my research and found that they were very effective and they're very consistent. Excellent company. Metagenics, also excellent company. Trouble is most of their stuff comes in glass, and so many of those that were shipped were broken. So I think that most companies out there are using what's called generics. Generics is that it's a company in Cambodia that produces 40 different bottle types with different labels, but all of it is the same crap that you get at certain stores, which I won't need to mention. That's not going to do anything. Okay, all of those are reject products that are maybe $1 a bottle. They put their fancy label on it. I could have done it myself. I mean, I had the opportunity. I refused because I don't think it's fair for people to spend $25, $30 for a bottle with a name on it when actually what's in there is just nothing. It's just basically crap. So you have to be careful in what you use. So that's what we decided on. There are certain companies that are good, but I would say in my experience, and it's quite extensive, I know probably every product on the market, because I like to study these things. I'd say 90% of stuff online is crap.
Yeah, I've heard some of that too.
Yeah.
How will the hormone replacement affect ITP, if any effect?
Okay, now idiopathic thrombocytopenia purpura is a condition where there's blood clotting disorders. It doesn't have a direct negative effect, but in general, because people ask the question about blood clotting and issues like that. Progesterone in pregnancy reduces blood clot. When a pregnancy is delivered, the immediate risk for blood clot is not before during the pregnancy. It is the 5 to 6 week period after the pregnancy where progesterone is deficient. The placenta is gone, you don't ovulate yet, especially with breastfeeding, and that's when blood clots occur. Why? Because it's unopposed estrogen. So when you look at that fact, as an obstetrician, I said, you know what? It's amazing. Nobody gets blood clots the first 6 weeks. And I studied that, and I used to give people, for the history of blood clots, progesterone therapy immediately after delivery. And guess what? They also felt better and they didn't have postpartum depression. I cured postpartum depression with progesterone, even though I was looking at the clotting disorder issue. So I started using progesterone therapy, high dose, either suppository or troche form, that basically replaced their progesterone therapy and they weren't having any zero postpartum depression symptoms. So I told it to a lot of psychiatrists who I knew, and they boohooed me away because they make a lot of money treating these people postpartum depression with tons of medication and they can't breastfeed. So to me, that's crazy thinking, but that's what happens. So I think blood clotting leads into other issues because the main balance, it's important, not for ITPs particularly, but also for the whole issue of clotting. So I have patients who are having surgery. The doctor says, well, we want to get you off your hormones, my hormones, because it's going to increase your clots. No, getting off the hormones increase your clots. Staying on the hormones reduce the clots. Plus, you sleep better, you feel better, you recover better. So again, we're dealing with a lot of doctors out there who are about 30 to 40 years behind Hormonify.
Yeah. Okay, so what is bioidentical hormone replacement therapy? And is BHRT safe? And why is there still so much fear and confusion surrounding hormone therapy?
Well, I think the reason I'll answer the last part first. The confusion and fear is because most doctors don't know what they're talking about. And I believe that medicine has become so radicalized in terms of pharmaceutical propaganda that doctors cannot think for themselves. They lose that ability to say things that are obvious in front of them should be treated a certain way because they basically become sheep. They couldn't be independent thinkers. I happen to have become a truth seeker my whole life, basically, is to research and figure out what the truth is that applies to everyone. And so that's why Hormonify is so successful. As far as what it is, it's basically a hormone replacement therapy program based on the hormones that your body produced your whole life. That's basically, in a summary, what bioidentical means. I used to call it natural. I used the word natural. In fact, my first company before Hormonify was a natural HRT. And that's not really necessarily good. Cyanide and strychnine are natural, but they can kill people. So I changed the concept of natural versus bioidentical because that's really what it is. It's bioidentical, and the word natural necessarily doesn't mean good. So a lot of these companies, by the way, for selling supplements, that's what word they use, natural, plant derived. Yeah, but it's estrone. Estrone, for example, in things that are Damiana, for example, Vitex, all of these supplements that you get in Astravan, all those supplements are estrone, which is the bad estrogen. So yes, it's plant derived and yes, it's natural, but it's actually increasing your risk of uterine and breast cancer. So it takes care of hot flashes and night sweats. But again, limited knowledge is dangerous. I'm sure we all learned that. Somebody must have told you that when you were a child. The little you know, that's dangerous. And doctors know very little and they become dangerous. So I think the key to all of this is to make sure that you educate yourself totally, or you find practitioners like Hormonify that have been doing this day in and day out for 30 years. And therefore, we know that people come with estrogen, we check their estrone level. We just don't check total estrogen, which a lot of doctors do. We check the estradiol level, the estrone level, and we see estrone level in the 500 to 1,000. Why? Because they're on estrone. And that's not good. It takes care of hot flashes, but it's dangerous. And everybody seems to say, the doctors, that's what I have gynecologists referring, oh, just go to the health food store and get some basically estrone. Duh. I mean, that doesn't make any sense. So it takes care of hot flash and night sweats, but that's not the key. The key is to take care of all 26 symptoms, including repairing a lot of the medical damage done by lack of hormones.
Yeah. Um, I've heard, some campaigns out there, they say they treat the symptoms, but not the cause. And I hear you say you treat the cause a lot. What is the difference there?
Well, the pharmaceutical model, which is based on what's called DRGs, which is diagnosing categories of diagnosis. For example, insomnia is a DRG. Uh, Lack of libido is a DRG. Vaginal dry. So we have 26 or 30 symptom-related diagnoses. And you give a drug for each symptom. That's basically it. So that made them a lot of money for many years. The model has been broken because it doesn't work. So the model that we utilize, which is really based on common sense and basically what I would consider traditional medicine versus radical medicine in the pharmaceutical industry, is that what works is basically treating the cause of all the symptoms, which is very limited. You can give four hormones and treat 20, 26, 28 symptoms. So you have to understand the relationship between the causational aspects, which is the etiology, the causes, versus the symptomatology. Yes, we do a symptom review. Yes, we do. We get a number. We say, you have 11 symptoms. You have 14 symptoms. But I don't care what they are. I don't care if it's 6 or 22. It's just for them to know when we do it again in 6 months to a year, how many symptoms do you have? And all of a sudden they have no symptoms. I said, you realize you had 16 symptoms a year ago? Oh, I don't even remember. Really? Yes. So it's a quantitative analysis that we utilize. But our general rule is that if you do not understand the cause of your symptoms, you're going to be mistreated. So that's the causational theory versus the symptomatology theory.
So how do you determine whether someone is a good candidate for hormone replacement therapy?
If they're breathing, they're a good candidate.
Yeah.
Those that are not breathing, I would not recommend hormone replacement therapy.
Okay, makes sense. What kinds of testing are typically done before starting hormone treatment?
With us or with other people?
Um, I guess break it down, however you want to answer that.
Well, with us, I'm a gynecologist and I treat women all the time for 40 years. So I want to make sure their bleeding issues, if they do have bleeding issues, are fully evaluated with an ultrasound because we want to make sure we don't lose any of those diagnoses like uterine cancer, endometrial hyperplasia. And so I think that's important to do. And we have people all over the world and all over the country, especially. We order them and they're done locally. We get the result, we go over it. And then we recommend that they go see XYZ doctor who will do a procedure if they have to. We make sure that that's fine. As far as lab work goes, we do a complete nutritional assays, we do complete hormone assays, we do whatever particular history that we need to get. Remember, we do an inflammation study because a lot of patients are suffering from a lot of inflammation and from whether it's nutritional or whether it's not. As I said, we individualize the program based on the history, but in general, we're pretty rigid as to what tests we need in terms of laboratory testing. Most importantly, the age, the weight, the sexual history that the patient has. It's very important because a lot of patients, they're difficult to get the history from because they're embarrassed that they haven't had sex with their husband in 6 months. And, you have to drag it out of them by just asking, how often is your intercourse? And they don't even have an answer. I said, when's the last time you had intercourse? Oh, it's been 6 months. But my husband's great. That's what they say. My husband understands. And I'm telling you, I don't know if he understands, but he may not. Okay. Maybe you're living in a fantasy world that you think he understands. So intimacy is part of the program and that's individualized. And we try our best to get that fixed as well. And that sometimes takes a little longer. But all the issues of lifestyle are addressed. It's multifactorial. We deal with bowel issues, to make bowel health important. We deal with neurological issues. We deal with endocrine issues. We deal with cardiac issues. Um, Women don't realize, and doctors don't realize that women who are on testosterone therapy, low dose, have less heart disease. All right. So in other words, there's so many things that are essential to understand as a clinician. And unfortunately, most of the doctors out there or nurse practitioners have a 3-hour course behind them, and they don't really understand the ramifications of what they're doing.
So how long does it take for women to start feeling better once they do begin treatment?
Well, some women feel better just meeting me, and we go through the history and they thank me. I feel better already. I don't understand what that is all about, but it's magic, and that's partly it. People feel that someone is listening and actually doing something about it instead of told that you're crazy. So doctors really have lost the ability to become healers. Healers meaning that it's not just what they do, it's how they do it. And I think at Hormonify, we really focus on that very, very intensely. It's a difficult area, but we're working very hard to also become healers for the patient and deal with all their issues. That being said, usually most of the symptoms get better almost right away, okay, as hormones improve. Symptoms like sex drive issues, hair loss issues, that's in the 4 to 6 month range because of the cycles that necessarily have to go through to fix those problems. But I would say by 2 weeks, most patients feel better. By our first visit, usually is about 6 to 7 weeks, and the vast majority of people are much improved. If they don't, then we have to analyze why they don't. What's going on with this patient that does not make them feel better, at least majority better, as opposed to 100% better. That's where clinicians have to have experience doing that. Sometimes it's tough. That's why it has to take someone with experience. Look, when I first started this for 10 years, not only was I criticized, but all my doctor friends used to copy me and they didn't know how to handle it. They didn't know how to handle problems when patients have they're not better, why they're not better. They didn't know the ins and outs, but they didn't develop the program. All they did was copy me and say, here, that's what Dr. Eckert does, so here, take this. So in other words, that's where a stage of we're at now in this country is that people are copying me. They make believe they know something, and as soon as a problem comes up, the patient calls me and says, "My family doctor tried, but I don't know what to do now." So that's unfortunate. But that I think takes a lot of experience. You know, when you ever go on an airline and you see the captain, he's not nervous. He's done this. He can do it in his sleep. He can do this literally in his sleep. He's done 10 million miles and he doesn't really care about what goes on. He's cool, calm, and collected. So if you don't have that experience in hormone therapy, you're going to overreact. You're going to start getting lab work every 3 months, which is absolutely insane. And I see that all the time too. They don't know what to do. They get lab work every 3 months. It's included in your care. What does that do with anything? Getting lab work after every 3 months depends on how many hours after the last dose you take it, depending what the levels will be. So they don't know that. So therefore, they'll get levels and they get it 2 hours after the dose, and then all of a sudden it's so high, they'll tell them to lower it, and then it gets too low, and they tell them to raise it. All of that is part of PTSD medical that we mentioned before.
Okay, I got two questions in the chat. The first one is, are there any side effects having too much estrogen? Having too much estrogen can cause, such as fibrocystic breasts or vaginal changes, for example, and what is the highest dose of estrogen you would give a patient?
Okay. So again, it's absolute value versus ratio. So absolute value is not that important. How much you give is not important. It's what the ratio is to progesterone. So if you're estrogen dominant, we don't give you any estrogen. If you're estrogen deficient, we give you estrogen enough so that the three areas that estrogen does help is vaginal dryness or wetness, dry eye, and dry skin. Everything else is handled by the other hormones. Estrogen is not the main hormone of treatment. It is a minor hormone. It's the fourth one of importance. So the misconception out there, due to false research by pharmaceutical companies in the 1990s that tried to push estrogen as the treatment for, we'll use the word menopause or hormone deficiency, they were wrong. That's why the studies show that it increased the risk of breast and uterine cancer and did not treat senile dementia or Alzheimer's or all the things they claimed it did. It did not help bone loss. By the way, a very important aspect of what we do is we cure osteoporosis. We have patients who are 85 years old who come in with diagnosis of osteoporosis. 2 years later, their bones are much better. So we've basically cured a major disease that can end their life. Do doctors put them on osteoporosis related medication all the time? Do they consider therapy that treats the cause of the problem? Nope. Why? There's no money in it. That's the bottom line. They don't have the energy to spend all that time doing what has to be done correctly to cure these people, especially women, of osteoporosis related symptomatology, including increased risk of fracture. So therefore, we cure the osteoporosis. We have zero in our whole community. And we have patients in their 80s and 90s. Some of them get better within a year, some 2 years.
Okay, we got some, maybe, I'm not, these are probably quick ones here. How often should you get lab work done?
As I said, we get lab work as an introduction to see all the things that we need to focus on. And what we try to do is utilize that information to make a plan. We do not use hormone levels after that, except when we cannot figure out what is going on, which means it doesn't make sense to us. So rarely does that need to be done. I would say less than 5%. So I don't like to get labs all the time, but if a patient, I had a patient yesterday, she wanted lab work and my nurse practitioner ordered the lab work and I said, everything is exactly as it's supposed to be, blah, blah, blah. Okay, I feel better. All right, that's fine. But we know what it would be because we've been there a million times. Now, when Sandra said I have a million patient months of experience, that means that I've seen a lot of months of therapy in my life, and I can tell you just by speaking to you what your hormone milieu is going to be. But I still confirm by laboratory testing in the beginning, so it's not hocus pocus. You get some objective data, but after that, a lot of it is not really very helpful. I think it can be detrimental because you're constantly changing levels, which is not good long term. I hope I answered that question. I even forgot what the question was.
Okay. I have another one that came in. Hi, I have Hashimoto's. Do you treat the thyroid as well? I am finding that my sex hormones need to be adjusted when my thyroid medication changes and vice versa.
Correct. So whenever you have autoimmune disease, whether it be Hashimoto's, multiple sclerosis, lupus, rheumatoid arthritis, scleroderma, all of those, you need to look at the inflammatory nature in your body. Meaning you have to measure inflammation, you have to treat inflammation, mainly nutritionally, and with high dose of progesterone. Progesterone is the major hormone of anti-inflammatory processes. That is an amazing work that was done about how progesterone helps the woman not reject the fetus. It modulates the immune system. It keeps it under control, not to overreact. Now, most doctors don't even know that. Ask your doctor, how does progesterone affect autoimmune disease? We use progesterone-based therapy, which we learned from pregnancy, to reduce your symptoms and get you off your medication or autoimmune disease.
Okay. I hope that answered that for you, Christina. Let us know if you have any more. What are some of the biggest misconceptions society has taught women about aging and menopause?
I'm not an anti-aging guy. I think aging is good. That means you're getting older and you're not dead. So I'm not an anti-aging guy at all. I appreciate aging as a good thing. However, you should be without medication chronically, and you should be basically free of all of the chronic diseases that are caused by lifestyle issues. Drinking, smoking, drugs, all the things that we all know can cause consequences as you age. That being said, hormone replacement therapy is a key issue, whether it be for men and women, to keep you balancing, keeping you in a way that you were when you were younger. However, it's not the most important issue. I think the most important issue is lifestyle, getting enough sleep, properly exercising your body through your life, not doing drugs, not drinking alcohol, not smoking cigarettes. I think all of that is super important. But I'm not an anti-aging guy. I don't believe that is logical at all. So I like the age. I mean, I'm happy I'm aging. I mean, otherwise I wouldn't be here.
All right, so some of that tapped into my next question. Are there lifestyle habits, nutrition choices, or supplements that can support hormone health alongside treatment?
Absolutely. We are very, very keen on utilizing supplementation, quality supplementation to assist you, not from the hormone side, but work side by side because so many symptoms are made worse by lack of nutrients. So we measure specifically, I developed three profiles. I call one the mineral profile, the omega profile, and the antioxidant profile. And we actually replace only that you need. I mean, I have patients who go to these health food stores and they have somebody with a high school degree. There's nothing wrong with that. It's just they don't know any very much. Who say you need this, you need that, you need this. How do they know? I mean, so we actually quantify it and we view that as far as your initial assessment, and we replace what you need, which is extremely important to know what your body is. Everybody's different. Everybody has a different composition. Everybody treats nutritional things differently depending on your ethnic background, where your family comes from, anthropologically. So I like to look at the overall picture before I make a decision. But a common mistake that people make and spend a lot of money is they get stuff that they go online, they read an article, and oh, this is great, NADH. What, I'm going to get that. And they spend $80 and they don't need it. Okay, so I only use what I think is necessary to replace the hormones and replace nutritional issues as individual patients need it.
Okay, and then we just have a couple more, and then we'll go finish up what's in the chat. So why do so many women feel dismissed when bringing up these symptoms to doctors? I think many of us have experienced that at some point.
Well, again, I think we referred to the lack of education that doctors have in this field. They're now, I've been doing this for so long, I've seen the scammers come and go. We now have big time scamming going on with patients. It's going to come and go in terms of how it's going to pan out. I've been doing the same thing for many, many years, and I don't use certain products that are out there to make the company money versus what's best for the patient. So I think that patients feel, like I said, not only dismissed, but they feel, like I said, PTSD medical, that they're anxious. They don't know who to believe. They don't know what to believe. The doctor puts them through, they put them on the pellet, they have bleeding, they do a DNC. That's it. That's the way the doctor deals with these issues. And it gets very frustrating for a lot of my patients. A lot of them have seen three, four doctors before they see us. And so I think that the dismissing of the patient's needs is not just because they're bad people. They don't know. They don't know what it is that they need to do. Nobody ever trained them and they didn't take the time to learn. I have doctors call me from all over the world and say, I have one of your patients. I have someone from Czechoslovakia, one of your patients, and she's doing great. What are you doing? So I tell them what I'm doing, but of course it's difficult for them to do it in Czechoslovakia. But what I'm getting at is that the issues are that if the doctor wants to know, there's enough material out there. I put out a lot of material, a lot of research, a lot of articles, and if they want to know, they can do it and they can call me. I had one doctor from New Hampshire, had a patient of mine in a small town in New Hampshire, and he was great. He's saying, she's doing great. What is this? I saw your package, asked me all the right questions, and I told him what he can do. He can call me anytime. And if he wants to put other patients on the therapy. So it's a grassroots thing that's going to go from doctor to doctor. But unfortunately, most doctors are pharmaceutical propagandists, and they're pushing drugs versus treating the patient for the best result for the patient versus the best for the pharmaceutical companies.
Okay, this next question is on joint pain, which many of us feeling. Can hormones impact joint pain, inflammation, or
Well,
body aches?
yeah, I mentioned that before. Yes, absolutely. Inflammatory changes are presenting as joint pain, also presenting as what is the increased risk of lupus, for example, in women between 46 and 51. Why is there a spike? Because the lack of certain hormones will increase the risk of inflammatory disease processes. You can go through with multiple sclerosis, you can go through with rheumatoid arthritis, and just general aches and pains. Now, that's true of men as well. One of the questions I ask men is when you wake up, are your joints achy? And yes, almost all of them need hormones replacement and their symptoms go away. So it applies to everyone. Level of inflammation is extremely important to reducing disease processes. So the body carries inflammation depending on their nutritional status, depending on their lifestyle, depending on their adrenal gland, and also, for women especially, their sex hormone milieu. So we have to address that, and we do address that. And it definitely makes a big difference. People have more energy. Why do the people fatigue? Why do they have low energy? Doctors don't ask the question. They put you through this test, that MRI, that colonoscopy, that, and everything is fine. Everything is normal. They didn't address the fact that you have low energy. And why? They didn't address the adrenal gland. They didn't address your sex hormones. They didn't address nutritional aspects. Why? Because there's no money in it. They just want to make the money. And I'm being cynical to some degree, but actually I'm being very realistic. This is what we're dealing with today in medical care around the country. And I have patients from every state except one. And I will tell you, it's constantly a problem when I get patients who tell me the same story over and over. And if that's your story, don't take it personal. There's nothing to do with you, and the doctor could be a nice person, but it's just lack of knowledge. That's why we're doing these, and we're going to use this video to educate doctors as well.
Okay. And what should women maybe they're in their 30s and early 40s start paying attention to now before symptoms become even more severe later?
Well, again, unless the symptoms affect your life, for example, premature ovarian failure is a very particular process that your ovaries fail very early. And we're seeing a lot of that. So if you're having symptoms of anxiety, depression, insomnia, dry vagina, no sex drive, midsection weight gain, you need to be evaluated. Okay. Do you have premature ovarian failure? Most doctors will say, no, you don't. You're too young. See a psychiatrist. You're crazy. So I think it should be more of a humanistic approach on how we approach women who are suffering those symptoms and not be judgmental. So in our practice, we have some doctors who refer these patients to us. They're very smart, they're good, they're quality, and they do the right thing based on their exposure to Hormonify. But in general, I would say a lot of patients are seeking their own answers, which they go on certain company websites that are scams that really do not help the patient. They just want to sell product. And that's unfortunate. They do not have physicians available to go ahead and properly assess, modulate, treat, and monitor. And I think that's a very important thing, which makes Hormonify cut above all the rest, if I can say so myself.
Mhm. So this question came up 3 times in the chat. Can you specify? Well, I'll kind of mix it. The main question was, do troches have gluten? And then can you specify the inactive filler ingredients in the troches? Are they sugar-free, gluten-free, calories, carbs? I don't know.
All of those things. And the particular Troche that we utilize has no gluten, is hypoallergenic. It is extremely high quality. And that's another good issue, though, is that we have patients, and 100% of the time when they use the local pharmacy down the street to save $6.42, they go ahead and fail because the quality of the gel has to be made on a daily basis, new and fresh. You can't use old stock gel. It does not hold together. It does not work. You can't absorb, and you're wasting your money. So that's another interesting aspect, is that unfortunately the quality of production of the product is also extremely important. So people who rely on patches, I have patients who come in with patches and I check their levels and they have no estrogen. They got no absorption. There's nothing in there. And in fact, the FDA closed down a lot of factories because of that. And you couldn't even get patches for a while because it's not produced properly with proper issues, especially if the factory is overseas. So what we try to do is quality is first, and we try our best because that's when we get consistently good results.
Okay. And Rosalie, let us know what kind of doctor, but her question is, what can I tell my doctor when she says, be careful with hormone replacement because there's been no scientific studies done on BHRT, so I need to be aware of getting breast cancer. Her gynecologist said that.
I've been doing this now, and then so first of all, the uh, the government just came out, the FDA just came out and said that all the studies that were done that showed estrogen causes breast cancer was felonious, was a scam, to scare people. Number two, we don't use estrogen-based therapy. We use progesterone-based therapy. And anyone knows who knows anything in medicine is that more pregnancies you have, the less breast cancer you have. Why? Because of progesterone. And that's a simple fact. You don't need a study to show it, just like you don't need a study that we need oxygen to live. This is well known in every single textbook and every single OBGYN course that's given in residency program. The risk factor of breast cancer goes down. It's inversely related to the number of pregnancies a woman has. Period. There's no controversy there. So what's the controversy? The controversy is that doctor is fear driven. She's afraid because she doesn't know what she's doing. And it's unfortunate, but that's why you have me. I'm not afraid. I'm not a fear-driven person. I know what I know and I understand what I know. Now, I cannot study in my practice. Everyone comes for HRT. So I can't put 50% of the people in a study control group and 50% get hormones because I'm going to have a lot of problems with dealing with these patients who go and get no hormones. So I can't do the prospective study. But the basis of our therapy is well established in the literature. Thousands of studies are done to show how progesterone affects a woman. Thousands of studies have been done how progesterone reduces the osteoclastic activity that produces osteoporosis. If she doesn't know any study, I don't know what she does in her free time. So I can't speak to that. But if she knows the basis of OBGYN and basis of women physiology and biochemistry, that's not an issue at all. And the other issue is we're in South Florida. There are attorneys in every corner that if I would be doing something that causes breast cancer, I would be sued out of business 50 times. We have not had a lawsuit because there's no evidence at all that what we do increases breast cancer, but there's tons of evidence by a clinical experience that what we do almost eliminates breast cancer and eliminates stage 2, 3, and 4. We have zero.
Mm. Uh, okay, this next question. Is it safe to get a mammogram every year because of the radiation?
Okay, so good question. 30 years ago, mammograms were recommended every year because they miss stuff. Now we have something called CAD, computer assisted detection. The radiologist doesn't even read it anymore. It's all written by computer. They don't miss anything. And the study has been done that shows that it takes about 2.5 years of a breast cancer to be detected on a mammogram. It's earlier on an ultrasound. So my recommended therapy that I use and never missed a breast cancer in 30 years, I've been using this for about 15 years, is mammogram every other year, ultrasound in the year you don't have mammogram, and have yet to miss a breast cancer ever. Tens of thousands of patients. Now, why is it not incorporated as a standard of practice? Because the radiologist will lose money. Just like thermography was not utilized because the College of Radiology outlawed it because they'd have to replace all their machines. That's the reason. So I'm on the inside. I see all this stuff. So the reality is a patient who have a mammogram every 2 years will reduce the radiation. Studies have been done to show that if you get mammogram every year, you increase your risk of breast cancer. You're radiating your breast for no reason. Doesn't improve your detection rate.
Okay. All right. So those are all the last questions I have. Did I miss any? Please feel free to, if anyone has any last questions, or Dr. Eckert, I'll turn it over to you to close this out. Oh, can you talk about peptides a little?
Yeah, we do peptide therapy. Very important to look. This is where I think FDA approval is necessary. I've researched, as 14 peptides I researched, I use one. And the one I use has been FDA approved, have been studied literally for 10 years. And the reason why RFK Jr. has set up the new committee in June, sometime they're going to be reviewing the other 13 peptides and decide which ones they're going to go ahead and put in clinical trials. It may take a year or two for them to figure out specific needs of the peptides, but now most of them are pretty experimental. Some of the data is good. I think some of them will be approved. The trouble I have with peptide technology is that it has to be standardized. There's a lot of gray market stuff that's coming in through China, through California, that I wouldn't touch. There's a lot of things that are very complicated in that arena in terms of black market and gray market stuff. But we use one peptide very effectively as an adjunctive therapy, and I think it's great. The inflammatory joint stuff that I'm seeing is also excellent. I am a member of the research committee in regenerative medicine, the College of Regenerative Medicine, and we're reviewing articles to show some of the peptides extremely helpful in joint and arthritic conditions. So I think that there's a future for it, but I think right now RFK Jr. did the right decision by saying that we need to study this further, quantify the results, and then approve the ones that are proven to be specific and helpful. I think there's a great future for it.
Okay. DIM with HRT, should I use? And if so, how much, please?
Okay, so there's one company that discovered that their therapy program really was terrible. So they had high levels of estrogen due to the patch, and they put everybody on DIM without measuring. And I think it's not necessary. It has to be evaluated. I do not use patch therapy. Patch therapy is the high and low, it's the peak and trough method. Extremely old-fashioned, not necessarily beneficial. We don't know what they are day to day. I studied it and I found that it was extremely unreliable. So therefore, we don't use DIM therapy on 98% of our patients unless they start out with extremely high levels. We have certain patients who we get the studies, estrone levels 1,000. That's their genetics. We lower it with either anastrozole, which is the synthetic, or we lower it with DIM. DIM is very difficult to give to everyone. I know that there's one program especially out there that puts everybody on DIM. To me, again, without specific reasoning, I don't think it's indicated.
Okay. And Dora, I'm not sure if there's a question here, but I had breast thermography this year as well as ultrasound and mammogram. Um, is there a direct question or on there with that, Dora?
That's too
Or
much, too much. I mean, if you're going to pay for thermography, then you don't need a mammogram. If you're going to just do a mammogram, you don't have to pay for thermography, just every other year, and do an ultrasound in the interval year. That's my program, and it works beautifully. Now, those on my program don't get breast cancer. I mean, the rare cases of breast cancer is so rare that, it's a big deal for us. But if that's the case, then I would say you're over diagnosing. Just like, for example, I review mammograms from hospitals, and it's perfectly fine. And then they say, we have an area of shadowing that we don't know about, mammogram 6 months. It's nothing positive. It's just something that you can follow up with, not a mammogram every 6 months. If you want, there's a mammogram and they do an ultrasound and you do this study and that study. It's all negative. There's nothing there. But they make up something to make it sound like, oh, you may have something. So let's do a mammogram in 6 months. Why don't you do a mammogram in 2 months? Why don't you do a mammogram in 2 weeks? What's a 6 month period of time? So therefore, there's a lot of arbitrary decisions made based on fear-driven behavior, like we discussed before. So it has to be logical. So I review mammograms all the time where people are recommending to have biopsies. There's nothing there. It's normal. Again, that's the experience that you get when you come to Hormonify. You get someone who's been doing this, and I've never missed a breast cancer. So in other words, you got to be careful who you go to. And most family doctors do not have the education or the ability to make that decision. So they'll go along with the radiologist and say, okay, mammogram every 6 months. Meanwhile, they're increasing your risk of breast cancer.
Okay. And I'm interested in becoming a patient. What do I do?
Um, I don't know. I think that you can go on the website and there's all the information there that you need to call. Usually what we do is that we do what's called a pre-consult. I like to meet and talk to almost all the patients who come in new to make sure we can help them. And that pre-consult's no charge. We just go over what they're looking for to make sure that we're compatible. I like to do that. I like to meet the patients and then usually refer to the nurse practitioners, or if it's a complicated case, I will take it on myself. So, Hormonify website, you can give the information out.
Yes.
That has all the information on how to contact us. And we have new patient coordinators that actually interact with you to make sure that everything is explained very clearly up front.
Okay. And I'll also send an email after this. And
That's
then
great.
Annette thank you, Dr. Eckert. Started your HRT about 4 weeks ago, and I'm so happy. Looking forward to speaking
Oh,
to you again soon.
that was probably
So
a plant. Huh? She planted in there. Okay.
it was Annette.
Yeah, we get a lot of happy patients, and I think that's the key. If patients feel better, they're going to continue the therapy. We have a lot of patients from other companies, I'm not going to mention their names, that it's a great referral source because they start the program, they don't feel any better because it's not proper. It's just not properly treatment, it's not complete. So therefore they search out, and a lot of them unfortunately fall for a lot of internet scams, and you have to be very careful.
Yeah. Okay. I have one question that I see a lot in the Facebook group, and it's about the testosterone shot. What are your thoughts on that? I know.
Well, in the 1980s, that's what was utilized a lot for men and women. Um, it's no indication anymore for that. We have testosterone through troche formation and other methods. Testosterone could be easily given without injecting. Because again, if you inject, now for men, unfortunately, we have to utilize injections. The best method. We cannot get the levels adequate to treat men. But for women, it goes too high and then it comes down. And the downslope of testosterone is a killer for women. That's why the pellet is so dangerous because these patients peak out at 1,000, 2,000, and they start coming, de-escalating down, and they come to me and they tell me, I feel like I'm falling apart, and of course, women are not meant to have levels of 1,000 or 2,000, so those are male levels and high male levels. So again, I see testosterone injection as a 1980s, 1990s thing. It's 30 years ago that I think should be not given in any case. We have rarely a need for a woman who's been on the pellet, who is used to very high dose of testosterone. We cannot get it on the troche form. We will supplement for a short period of time, giving her injections of testosterone. But that's only those that have been ruined basically by the pellet therapy with high dose testosterone.
Okay. And then this last question here is what can be done to get, if anything, to get insurance to pay for the trochees?
It's a good question. If that's an attorney, I'd like you to call my office. I've looked into that. Hormonify is getting big enough where every state has to be addressed in terms of why insurance companies are getting away with not paying for prescriptions for supplements, or for that matter, prescriptions for hormone therapy written by a physician. And it's a matter of just suing. I mean, it's a matter of properly creating 5 lawsuits in Florida that shows that the patient was treated unfairly. You have to win each case, and then you can do a class action. So that's going to take a lot of money and a lot of work by state to rectify the problem established by pharmaceutical industry lobbies. And I do believe that it's a very important issue that has to be addressed at one point. And Hormonify may address that in the future because I think it's very important. Why, logically, would this not be covered, but prescription synthetic stuff, for example, that causes all sorts of problems, be covered? So that doesn't seem right to me. And yet, on the other hand, the legal system is established so that it's very difficult to get the insurance commission involved unless you legally file action. which then has to become a class action involving all the people in Florida that have been denied. I think it's going to happen. I think there's going to be a change when people rise up and say, this is not right. You know, I don't want to take synthetic stuff. I also don't want to take a pill, which doesn't work as well. So until that happens, unfortunately, there are certain companies that are on the internet that do marketing, millions of dollars of marketing that push pharmaceutical treatment of hormone replacement therapy without bioidenticals and not being complete. And unfortunately, the those are covered by, and people are saying, hey, it's covered, so it's cheaper. I'm going to go for it. But it's not correct, especially in increasing the risk of breast cancer and not treating all the symptoms that are necessary. So I think we're in a transition in that period of time. But Hormonify is growing to the point where it may very well happen soon.
Okay, wonderful. Any last questions? I think we're right at the end here.
Okay.
Yeah,
Well,
and if you
good.
want to close this out. Mhm.
I think we did very well. Thank you very much for everyone to listen and tell your friends. And this video will be available, I understand, on our website.
Yes.
Okay,
Absolutely.
fantastic. Thanks, everyone.
Oh, and the next one is June 18th. Make sure
Oh,
you'll get an email out. So make sure to gather and support and share it with others so that they could also benefit and learn. So we'll
super.
send that out.
Okay. Thanks, Sandra.
Thank you.